All right, so we're going to do, we have a slide dedicated to each valve problem, I should say. So we're going to have 3 problems with our mitral valve. We're going to have mitral stenosis, mitral prolapse, mitral valve prolapse, and mitral regurg. The next 3 slides will go over those and how they're different. Just to recap everything we've been saying, we're just going to break it down a little bit more and walk you through each step, right? So this is mitral valve stenosis. So the mitral valve is either incompetent or is it not opening all the way? Which one is it? It's not open all the way. So here our mitral valve is stenotic, right? It is not able to let blood pass easily into this left ventricle, right? Left ventricle is not going to have problems that the left atria is, right? The left atria is going to grow and grow and grow and grow, and it's going to push on what? What's behind the left atrium? The esophagus. So you're going to have trouble swallowing as a side effect. It's also going to grow and grow and grow, and that's going to make the conduction through the atria abnormal. So you can have AFib or aflutter, right? So that could be a risk with left atrial enlargement. That's going to put extra pressure on the left atrium, and then it's going to, that can then translate into the lungs, because the lungs are trying to just deploy the blood into the left atrium, right? There's no like kick of the left atrium of the lungs. All that blood just comes from the lungs and goes into the left atrium. But if the left atrium has all this pressure, it's all backed up, you're going to start getting lung symptoms, right? And that's called left heart failure symptoms, right? And then, of course, that can put extra pressure on the right ventricle eventually. So it can decompensate, but usually they're going to seek out help when they can't breathe good, right? So that's the idea behind left atrial enlargement, extra left atrial pressures, okay? So yeah, it can, if not treated, it can lead to RV failure, but the first thing you're going to get is increased left atrial pressures, increased lung volumes, or not lung volumes, but increased lung pressures and difficulty breathing. And then now that's going to start leading to left heart failure symptoms, right? So this is a systolic or diastolic murmur. It's a diastolic murmur. Why is it not systolic? It's a valve that cannot open up, right? And it's supposed to open up during diastole, right? So during diastole, this valve is supposed to open up here, right? We're supposed to dump all this blood from our atria into our ventricles. That's the filling of the ventricles is diastole. Yes, there's an atrial diastole too, but we're talking about, when we say systole or diastole, usually we're just talking about the ventricles unless we specify otherwise. So the ventricles are filling up with blood, and they fill up with blood through the mitral valve, right? And if it's stenotic, it's going to start creating extra sounds as it goes through, right? And we're going to hear those sounds during systole or diastole. As blood is going through the AV valves, the mitral valve in particular, it's going to be diastole, right? So it's a diastolic murmur. It's described as a diastolic rumble, right? It's just it rumbles during diastole. So it's going to be bump, bump, shh, bump, bump, shh, right? So we're hearing it after S2, right? We're hearing it before S1. We are not hearing it after S1, and we're not hearing it before S2. So that sounds like a great test question. Those are 4 options, right? Select all that apply. We got an E in there. We can add it. It sounds like a friction rub. No, right? So those are all the ways you can ask those questions. So in your study groups, you should be asking these questions. Try to trick each other. Try to say, hey, is it before or after S2? Is it before or after S1? Right? So you can go through it, and that's why valves are hard, because if you don't know the basic physiology and the basic anatomy, how it works normally, it's like, well, that's mitral, that should be, that's a problem with the opening, and when that happens is during diastole, going from left atrium to left ventricle, therefore I'm going to have problems during diastole, which is S2 to S1, okay? So it does happen a little bit late because you're going to hear more issues with the atrial kick, right, as it pumps. That's the way you hear the most pressure. When you're putting blood from the left atrium and left ventricle, the last 20% of that diastole is the atrial kick, right? Last little piece is atrial kick, and you're definitely going to hear it there. Okay, so if you have more preload, if you have more volume going through that stenotic valve, are you going to hear better or worse? You're going to hear a lot better, right? So more blood equals more murmur in this case, and that is the usual for all of our valves, right? And there are exceptions, and we'll point out those exceptions. But more blood means more murmur. So if we put a whole bunch more blood in that left atrium, that's going to put a whole bunch more blood through that mitral valve that is stenosed, and we're going to hear the murmur louder. Where will we hear it louder at? Fifth intercostal space, midclavicular line. right? You will hear it at the aortic area, but you're going to hear it better at the mitral area, right? So when we talk about our different areas, if you were to superimpose the heart underneath this diagram, our mitral valve is where? It's pumping blood from the left atrium to the left ventricle. It's pumping the blood this way, right? So let's do another color that shows up. So all the blood is going this way, right? That's going from left atrium to left ventricle. That's why you hear it best at the fifth intercostal space. You will hear it echo, I guess, at the aortic area, but you're going to hear it best at the mitral area. Okay. There sometimes is an opening snap that can be appreciated. Sometimes that happens. That's with it has like stenotic. It's very, very stenotic, and then it opens up, and you can hear that opening snap. But really, it's going to be diastolic. You're going to hear more of that murmur with more blood going through. And there are maneuvers you can do to do that. You can have them squat, and you're going to hear it better, right? That will put more blood into the heart. You can raise their legs. That will put more blood into the heart, right? So if we have someone sitting like this, right? There's a certain amount of blood in the patient, right? And there's blood in the legs too. Now, if we raise them up, right? You put all the legs in the air. All that blood is going to spill. All this blood is going to get added to that heart, right? And you're going to hear it better, okay? And if they were to stand up, all that blood would now go into the legs, and you actually hear it less. Okay, so then afterload. So when we talk about maneuvers, we can increase afterload or increase preload. You're not going to really hear much effect with afterload. Okay, so again, we have a stenotic valve here. And why is it stenotic there? We have some junk in the way. What kind of junk might that be? It could be calcification, or it could be like infective endocarditis. We could have an infection of the valve, right, that has accumulated there. Okay, so the pressure in the left atrium has gone from 10 to 25. It's really increased its extra work, and that atrium will then dilate out and then push on nearby structures, causing AFib, causing dysphagia, and that can then also lead to left heart symptoms. All right, so that's mitral valve stenosis. Any questions on how that works? So we're just taking all the things we just talked about, and we're just kind of applying them to each valve. So mitral valve prolapse. Again, mitral valve prolapse is asymptomatic. All right, you can really only hear it. You can only appreciate it on echo. People are not going to come in and complain of mitral valve prolapse. All right, but you can auscultate it. There are some things you can hear, and mitral valve prolapse is when you have a valve that is it's a dilated valve that is causing noise inside the left atrium. So if you imagine like a parachute, or if you ever had one of these toys, if you were poor in the late 80s like I was, this was the toy you got, right? It came out of Cracker Jack or whatever, and it popped open, right? And it made a noise sometimes. And that's what's going on here. This valve is not touching like it should. The valve should close and touch perfectly, right? There should be perfect closure of the valves, right? If I'm closing my fingertips here, they should close nice and easy, right? But if there is a lot of extra tissue, it's going to start causing noise, and especially when it billows out, right? When it billows out, and I have a lot of extra tissue, we're going to go in there. It's going to cause a lot of popping noise as it billows into that left atrium, right? Like a parachute going off, right? So as we pump blood into the aorta, also you're putting pressure up against that valve that should be closed, right? And it's going to pop out, right? It's going to pop out like a parachute, and you're going to hear that whoop noise, right? You're going to hear this noise here. All right, so that's the idea behind mitral valve prolapse. It's a noise that is heard when? During systole or diastole? During systole. It's a systolic murmur. So you can hear this clicking noise. I don't know what I describe parachute opening as clicking, but that clicking happens because we have extra tissue. We have extra mitral valve that is growing there. All right, so we can appreciate that, and that click can move further away from S1 to S2. Notice it's between S1 and S2, because between S1 and S2 is systole. Okay, so it's a systolic murmur. They call it a mid-systolic click. All right, it's billowing or parachuting of the valves into the left atrium. And where are we going to hear it best? You can hear it at the mitral areas, right? So that's the idea behind a mitral valve prolapse. And then mitral valve prolapse is different. It's not what you expect. You expect if they have more blood, I'm going to hear more murmur, right? That's more blood against that parachute. Well, if I have less blood in the heart, I'm going to have more parachuting action, right? This is if my heart was less in volume, it's a different color here, right? Come on, you can do it. If my volume of my heart was less, it was more narrow, that's going to cause more parachuting action, right? It's going to cause more clicking noise, right? So you have like a heart, I think is here, a heart that is more compressed, right? It has less blood, it has less preload, less volume, right? That's going to cause what? More sound. So more blood in mitral valve prolapse causes less sound, because more blood is like letting it, it's not going to billow out as much. The blood is kind of easing the opening of that parachute, right? That's the idea behind a more blood is less murmur with mitral valve prolapse, right? So if we squat or raise the legs on this person, you're going to hear it less, right? If you have them stand up, that's going to make the chambers close, that's going to decrease preload, and you're going to hear it more. All right, so that's the idea, if you're widening the heart or you're narrowing the heart. Right? If you narrow the heart, you're going to have that extra tissue is going to cause more noise, right? During systole or diastole? During systole, okay? And then increasing afterload. So afterload, usually if you put more pressure through on a valve, it's going to cause it to be louder, except for mitral valve prolapse. So mitral valve prolapse is the one that is the exception to pretty much all the other valves, right? So if we've increased afterload, like where squatty will do it too, that'll put extra pressure on the arteries and the pelvis. If we are like squeezing our hands, that's going to put extra pressure for the aortic valve to open up against, and also for the mitral valve to, it's going to cause it to open a little more gently, right? If we have a lot of, less pressure, right, it opens really easily, it's going to billow out just fine. Okay, so that's the idea behind MVP, mitral valve prolapse. It is the opposite of what we expect, right? And the only other exception is aortic stenosis is like this too. All right, so we describe the normal with mitral stenosis, which is nice, but mitral valve prolapse is the different one, unfortunately. Okay, and it's all discovered with the echocardiogram back in 1983, so it's their fault. All right, so mitral regurg. So our valve is incompetent. Can the door close all the way? No, the door is not closing all the way. It is regurgitant. There's blood going through the door when it should be closed. All right, so when should that door be closed? During what? Good, it should be closed during systole. Our mitral valve should be closed during systole, and this valve is not closed, so I'm going to hear it during systole, right? This blood flow is, so here we got our heart pumping blood through or behind the pulmonary artery there into the aorta, right? Our left ventricle is squeezing during systole, and now our mitral valve is incompetent, so all blood is also being pushed into that left atrium. So right here's a better picture because it has arrows for both processes, but our left ventricle is pumping blood into the aorta, but this valve is incompetent, so it's also pumping blood into that left atrium. And that left atrium is going to get extra volume, it's going to get dilated, we're going to get AFib, we're going to get dysphagia, and then we're going to get left heart symptoms, such as what? Pulmonary edema, which is pink frothy sputum, we're going to get dyspnea and exertion. Those are all signs of a valve of CHF, and the CHF happened because of the valve problem, right? So here's what kind of test is this? A TTE or a TEE? This little scope right here, we're going behind and we're looking at that valve really closely in 8K resolution. That's a TEE, right? So TE is the best way to look at valves, and it's right there in the esophagus. You can see how close the left atrium is right up against the esophagus, right? So you're going to hear this murmur during systole or diastole again. You can hear it during systole. You're going to hear it all the way through systole. There's no like opening clap or opening snap or whatever. It is during the whole thing. It's incompetent. The door is blown open, right? The door, blood's going to flow through it just fine, right? But during systole, blood is going backwards through that valve, right? And you actually have these little cords that are holding on to the valve, so they're really going to start flapping in the wind, right? They're going to be like this. They're going to all flap into the wind, and we want to, then you're going to hear that problem, okay, during systole. All these problems are occurring during systole, so it's a holosystolic murmur. It's not like where it's louder at one part and smaller at another part. It is through the whole systole, right? And where am I going to hear this the best? Sounds like a good test question. A, B, C, or D. I'll probably put Erb's point in there because nobody uses Erb's point anymore, but we'll throw it in there just for fun. Where would you hear it best? B? Nope. B is the what area? That's your pulmonic area. D would be the correct answer, right? We would hear best at the mitral area. We hear mitral issues, mitral valve issues at the mitral area. Okay, so that's kind of those kind of tie as far as is it systolic or diastolic, or where do I hear it the best? Those are two things you can do every day when you're clinical. Is say, hey, I hear something weird between S1, S2, and I hear it best at the mitral area. Well, you have a systolic murmur. What are systolic murmurs? Either mitral regurg or mitral valve prolapse. And you can go in there, you can start raising their legs up, you can start having them stand, and you can say, well, I hear it best with this or that, right? Because you're going to, more blood equals more murmur, except for mitral valve prolapse, right? So you can assess those things. But really what they're going to do is let's get an echocardiogram. Let's look to see the echocardiogram they got yesterday. Like sure enough, there it is. They got a mitral valve regurg, right? So it's a holosystolic murmur. There's no click or touching of valves or anything. It is just there between what? Between S1, S2 or between S2, S1? Between S1, S2. Is it before S2 or after S2? After S1, that was the question though. It's before S2, right? So that's the idea. If it's a systolic murmur or a diastolic murmur, okay? So it follows the rules just like mitral stenosis, more blood, more murmur, and more afterload, more murmur as well. Okay, extra squeeze on the heart, left ventricle has to work against, right? Left ventricle afterload is the pressure the left ventricle has to overcome. The left ventricle is squeezing at a really pressure of like 110 diastole, right? It's squeezing. That's gonna be a lot of blood out the aorta, but it's gonna be a lot of blood flow through that incompetent mitral valve. So you're gonna hear more murmur. Okay. All right, so aortic stenosis. So aortic stenosis is where the aortic valve is not opening all the way. It is stenotic. It can be due to age and calcification. It can be due to just all the things we talked about with valvular causes, right? So wear and tear, atherosclerosis, all those things can cause our aortic valve to not become incompetent, but to become stenosed and not working. So you get thick, calcified valve leaflets. That puts a lot of pressure on the left ventricle. It's working super hard now, and it can lead to failure the quickest, right? It's also the most deadly valvular issue because all of a sudden you're exercising a lot, right? When you exercise, what happens? The SNS kicks in, and what happens? You're going to squeeze all your periphery, and now that's extra work for that left ventricle, right? And then you're trying to push, and trying to overdo your left ventricle, and then now it's requiring all kinds of oxygen, and the blood cannot leave the left ventricle because you have a stenotic valve there, and now that's going to lead to a dramatic reduction in blood flow to your coronary arteries and lead to sudden cardiac death, unfortunately. So this one presents with chest pain. Like this is like when you say like chest pain for valve diseases, this one makes the most sense because you're not going to get any flow to our coronaries, right? So that is the most important takeaway. That is, it can cause sudden cardiac death. Before that, of course, they're going to have chest pain. Okay, and then over time, yes, it will cause the left ventricle to work super hard, and then it can fail, and then it can lead to left heart symptoms. That will happen. As far as like the characteristics of it, I'm going to hear it best when during systole or diastole. You hear it best during systole. That's when my left ventricle squeezes, and that's when blood is flowing through my aortic valve, right? And if I put more blood flow through that aortic valve, am I going to hear it better or worse? More blood, more murmur. That makes more sense. More blood's going through that tight valve, I'm going to hear it better, okay? And then it's a systolic murmur, like we mentioned. So is it before S1 or after S1? It's between S1, S2, which is after S1 and before S2, right? So it is, here's S1 right here, and here's S2. Remember, how do you know if it's S1 or S2? Which one's the start of systole or diastole? Well, I can change this 1 into a Y, super easy, right? I can't change a 2 into a Y as easy. So S1 is the start of systole. It is a crescendo decrescendo pattern, right? So when you was a music major before nursing school like I was, this is it's a music thing, right? So it starts off really soft and it gets really loud and then it then dissipates, right? You can imagine the stenosis is really trying to overcome it and it sounds like a tea kettle, right? It's zzz, and it gets louder and then it gets quieter, right? It's a crescendo decrescendo pattern. So it's a systolic murmur, right? And it gets bigger and louder, and then it gets softer throughout systole, right? So it's bump, 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 shh, bump, bump, shh, bump, bump, shh, bump. So it gets louder during systole, right? So that's the idea behind aortic stenosis. We have an aortic valve that is not competent, or not competent, because I don't want to confuse you. It is not opening all the way. It's not functional as well as it could be. Okay, and you can actually tell that on in the ICU they have arterial lines, but also we have SpO2s out in the wild, which is the Med-Surg feels very wild sometimes, right? So out there they have pulse oxes, and you can look at the pulse ox. Oh, might have some aortic stenosis, right? You can tell that they can't really squeeze that good. Their systole is not going to be as high as it could, right? Because they take a lot of effort to squeeze out that blood. So you can see here's normal right here. You can see the systole is lower. And because it's lower, you got lower systolic blood pressure coming out of your heart. Your SNS is like, what the heck? Where's all my blood at? So it's going to start to squeeze the periphery, and that's going to raise the diastolic or systolic blood pressure if you squeeze the periphery. It's going to raise the diastolic blood pressure, right? So we increase afterload, so we're going to see our diastolic blood pressure go up. All right, so what's the difference between systole and diastole called? Systolic blood pressure minus diastolic blood pressure is called mean arterial pressure is the average pressure. That's 1/3 the systolic plus 2/3 the diastolic. What is systolic minus diastolic? It's called the pulse pressure, right? It's the difference between systole and diastole. So when you have 120/80, that difference is 40. If you have 120/100, that difference is 20. Right? That is not good. The reason why that might be happening, why is it 120? Because the heart could be contracting harder, but it's difficult to get the blood out. So it's only hitting 120 when it's able to squeeze out all of that blood, right? This is the left ventricle right here. It's squeezing, and then finally it comes out, right? Just like a fart, it's going to be soft at first, and then it's going to get really loud, right? And then it's going to dissipate over time, all right? So I'm not talking about the smell, we're talking about the noise, all right, the murmur, all right? So we have that murmur that's going to get really loud, and it's going to take a second. It might not hit the max it could, right? So the systole won't be as high, and our pulse pressure will be diminished, right? It'll be narrowed, as we call it. All right, and then afterload. This is the explanation for afterload. Don't get too detailed into it, but if you do give more afterload, you imagine if I make the heart work harder, I should get a louder noise. It's not though, right? So when your heart has to work, when the afterload is really high, it actually makes a quieter noise because it's going from an area of really high pressure. So this ventricle is working really hard. It has to achieve a systolic blood pressure of 200, right? And then if the outside is really low, the diastolic is really low, that's going to be a really loud noise. Right? But if it was going from 200 to 100 diastolic, that's not going to be as loud of a noise. So this explains it, but we're not going to get too detailed into why that happens. But we can explain more about how that happens. But it's going to be with more afterload, it makes it quieter actually. So how do I provide more afterload to somebody? I can make them squat. We'll do it too. I can make them squeeze their hands. These are things that would make the murmur quieter. Okay, so that's the idea behind aortic stenosis. More blood, more murmur, that checks out, but more afterload means less murmur. Yes?
So if you increase preload, then you're going to have more blood, so you're going to have more of the sound. But if you increase afterload, then you're going to have less of the sound.
You have less sound with more afterload. So the rules are of valves, more blood, more murmur, more afterload, more murmur. The exceptions are aortic stenosis and mitral valve prolapse. So mitral valve prolapse is both exceptions. It's more blood, less murmur, and more afterload, less murmur. That's for mitral valve prolapse. For aortic stenosis, the exception is the afterload piece. More blood, more murmur, that checks off, right? but more afterload, less murmur. Because I mean, imagine if it's squeezing really hard, the left ventricle is working, and it's squeezing from an area of really high pressure to an area of really high pressure. The noise is the difference of those two, right? So if I have high afterload and my heart came out at a really high speed, it's not gonna make much noise. But if the afterload is really reduced, that's gonna make a lot of noise. Okay. So these guys need to have a good volume. You don't want to take away their volume, because just the blood that does come out of the left ventricle, you want to come out, right? So we have to be very careful with diuretics with these patients. All right, so our last valve is aortic regurg. Our valve is incompetent. It is not closing. Our aortic valve is not closing. Why is it happening? Maybe we have a dilated left ventricle, right? They have long-standing anything that causes heart failure with reduced ejection fraction. They have their old age, or they were hypertrophied and now they're dilated. So we have this valve that is this ventricle that's really dilated, and now those aortic leaflets are not touching each other anymore, right? So now we have blood going back into the left ventricle. So that's blood that is being ejected into the system. All that blood goes in the system, and all the blood falls right back into the left ventricle. Okay, so we can appreciate that on our pulse ox as well. It's going to be during systole, all the blood's going to go all the way out. There's no resistance at all, right? All that blood just leaves the heart, and then all of that blood just falls right back into the left ventricle, right? So all the blood just leaves during systole, and all the blood just falls right back down during diastole. And should that blood fall through diastole and through the aortic valve? No. So that's called a diastolic systolic murmur. It's called a diastolic murmur. And it's called a diastolic, what they call a rumble, I think, right? So you hear it during diastole. So if it's bump, 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 it's bump, bump, shh, bump, bump, shh, bump, bump, shh. I'm hearing a diastolic murmur. And then where do I hear it the best? After S2. So between S2, S1. So here's S1, here's S2. I'm going to hear it between, and here's S1 over here. All right, I'm going to hear it during diastole, which is between S2, S1. Okay, and on the test, I'm going to give you all these things. I'm not going to just give you one thing and say, hey, they have increased afterload and this happened. No, we're going to give you all the things. I hear it best at this area. I hear it during systole or diastole, and I did this maneuver and it was louder or quieter. Okay, so I'm going to give you all three elements. All right, so you're going to be able to say if it's an aortic murmur or a diastolic murmur. Sorry, an aortic murmur or a mitral murmur, and if it is systolic or diastolic, that will tell you which one it is, and also it'll tell you, and the maneuvers are just an extra flavor. Okay, so there's a characteristic of water hammer pulse where all the blood ejects, and then it comes out, and then it bounces against the left ventricle, and then it bounces again out. So they have like what's called a bifid pulse. You can feel the pulse twice, right? So you feel the initial bounding pulse, right? You feel the initial pulse, but then you feel an extra pulse as well. All right, and then there's Quincke's pulse, which is just the cap refill goes away. And why does the cap refill go away? Because all the blood went to the periphery and then it bounced right back into the left ventricle. So we'll see if this video works. But you can see the blood leaving, it's like disappearing. You can actually appreciate the cardiac cycle in the fingertips. Okay, so that's aortic regurg, and then that's going to put extra pressure on the left ventricle, and that can lead to left heart failure symptoms. And it follows the rules: more blood, more murmur, right? More blood goes out, more blood's going to come right back through the aortic valve. And then more afterload. If more afterload, that's going to also squeeze more blood through that, through that, because the blood's going to go out during diastole. Blood should get squeezed in the periphery. Right? And if it's difficult to squeeze in the periphery, it's going to squeeze much nicer back where it came from, right? So that's more work, more murmur as well. All right, so note on auscultation zones, just a recap from first semester, all your different locations, right? So midclavicular line and fifth intercostal space is your mitral area. And you can see this zone here, that is where the blood flow is coming into, is going, right? So in mitral murmurs, all the blood is, change color here, all the blood is coming down this way. It's falling from the left atrium into the left ventricle, so I'm going to hear it better there. Okay. You can grade these. You can say, can I just barely hear it with a stethoscope, or can I hear it great with a stethoscope, or is it pretty loud, or they might be able to feel a thrill, right? You'll be able to palpate their chest, and you can actually feel the murmur as it rumbles through those incompetent or stenotic valves. Okay, so you want to differentiate it. Can you hear it between S1, S2, or S2, S1? And then is it systolic or diastolic murmur? There's a mnemonic called arms parts. It includes your right-sided murmurs, but arms parts, so aortic regurg and mitral stenosis, arms are diastolic. Okay, and there's other characteristics of it, and then you can memorize this, but if you think it through, it's like, well, that's regurgitant. If that's not working, I'm going to hear it during systole better or diastole better. We're trying to give you the why between it, or you can just memorize the whole thing, and if you have an eidetic memory. And where should you not memorize, but where should you hear? Where will you hear the murmur the best? On your stethoscope, on this side or this side? A or B? You're going to hear best on B for bell. All right, so here's a summary of the whole thing. So this table summarizes the past few slides and treatments, etc. So this is all valves here. All valves have symptoms of poor cardiac output, right? Which one's the most life-threatening? This could be aortic stenosis, which has a crescendo-decrescendo pattern. And when you're trying to figure out which murmur it is, first step is it systolic or diastolic, right? Next step is, where do I hear it the best? I hear mitral murmurs at the where? Fifth intercostal space, mid-clavicular line, right? And then if I hear best with the aortic valve, or where do I hear aortic valve the best? It's going to be this second intercostal space, right sternal border, not left sternal border, right? Not mid-clavicular line, right side. It's going to be the right sternal border, right? On the previous slide, we pointed that out, where the aortic area is, right? Here's your different maneuvers you can do, right? More blood equals more murmur, except which one? That guy, right? That one that's highlighted. So when you see it all on one table, that's the idea behind studying. If you put it on one table, you can actually say, well, shoot, that's the only one that's different. That's the one that's probably going to get tested on, right? So if a test question maker has to write test questions, they're probably going to test you on things that are different. Otherwise, they're making SATAs, and that's also evil. All right, so then we have, what else is more afterload? Usually means more work through that valve and more of that valve problem, except for these two, right? Aortic stenosis is the exception for more afterload. It causes less murmur. So that's, by the same token, less afterload means more murmur, right? So that's the idea behind the different valve issues. What type is it, stenotic or regurgitant? Only one of them is prolapse, and that's mitral valve prolapse. Right, and then what are the symptoms of diagnostic tests? We're get echo for everybody. Echoes are always going to be there. Right, I didn't even put it there, but echo is for everybody. And we got two types of echoes. What are the two types? We got T, which happens first, TE or TTE? TTE is always happens first, and then TE happens next, right? And then maneuvers you can do. There's examples of maneuvers there, and the complications. CHF can happen. And then if you can get poor cardiac output, and we know what poor cardiac output is. That's chest pain, shortness of breath, hypotension, confusion. SAD is another way to check those boxes as well. And the treatment usually happens when you start getting heart failure symptoms and poor cardiac output symptoms. Unless they're older in age, we might then not do that. We might just start anti-heart failure treatment. Okay. There's cath lab options and there's open surgery options. Okay, we're not going to really focus on right-sided murmurs for this test, right? That's a whole other thing. Right-sided murmurs usually are not that common, and also they are, that's kind of, that applies, right? That's usually has to do with respiratory dynamics, where you talk about more about right-sided problems, right?